Okay, so good evening, everybody, and welcome to this postgraduate lecture series. And today we're going to talk about a very interesting issue of hypernatremia. As you are aware, the postgraduate lecture series is focusing about different aspects of pediatric endocrinology, and we are planning over the next 3 years to complete about the entire aspect on that regard. So we had this 14-year-old girl who presented with failure to thrive. And actually at 14 days, she was lower as compared to the birth weight. And that's a very significant finding in that perspective. She was entirely breastfed and was found to have a sodium of 182. So this was a very devastating scenario, very difficult to manage. And what it was found out was that this was actually what is known as breast milk related hypernatremia, in that there was concentrated blood of a sodium very high and concentrated urine, meaning that body is trying to eliminate sodium but it is unable to. So this was a breast milk related hypernatremia, which is a lethal condition, a avoidable condition, which we should try to avoid if there is enough feeding evaluation in that setting. A second situation was more of a iatrogenic problem. A 3-month-old girl with altered sensorium was found to have hypernatremia, sodium of 170, and a urinary osmolality was low. Now, as I'll discuss in the first case, the main thing to look at hypernatremia is what is the urine. If you have a concentrated blood and a dilute urine, like in this case, your diagnosis of diabetes insipidus is already made, and you do not need to worry to do anything else. You have to go for an AVP response. Now, what unfortunately was done in this case was that they were advised a water deprivation test. Somebody who's already water deprived, who has a severe dehydration, if you do that, will develop seizures. So while we need to be careful in terms of assessment, we need to know what will be the right strategy. And this is what we'll discuss subsequently from that perspective. So hypernatremia is a relatively rarer condition as compared to hyponatremia, which we discussed last time. But this is one which is associated with significant complications in both in terms of assessment, in terms of management as well. And this was a classical case of DI in which we didn't need to do any water deprivation, and easily we could have made the diagnosis in that perspective. So today we are going to talk about a bit about pathophysiology. Then we'll talk about criteria and etiology by Dr. Sain. I'll touch base about evaluation and management. And finally, we have the Q&A session in which we'll keep it interactive. So all of you can put your answers and we'll see how well our class has gone in terms of that, in that scenario. All of you can go and have a look at our website, learning.growsociety.in, which has got multiple information pathways, courses with regards to pediatric endocrinology, YouTube site, which has got multiple videos, and a learning platform which provides evidence-based validated learning in pediatric endocrinology using practical tools for diagnosis and assessment in that regards. We specifically have a 3-year online and a 2-year offline fellowship program in pediatric endocrinology, along with pediatric endocrinology for postgraduates, specifically targeting the topics which are very, very relevant for pediatricians and pediatric endocrinologists in the form of growth, puberty, thyroid, calcium, electrolyte, and it has got a lot of interactive videos, texts, which are available from that perspective. We cover 3 specific free webinars every month in the form of specific to a particular topic, which is relevant for a pediatric endocrinology perspective, from a pediatric perspective, and finally, the postgraduate lecture series, which we try to cover specific topics. And we have a schedule which is there for the next 3 years, which will basically cover the entirety in that scenario. We've got publications, both basic and advanced pediatric endocrinology, to cover the entirety. And you can access our mobile application, which provides validated tools to evaluate, assess, and manage complicated endocrine conditions like hypernatremia. Discussed is a rarer manifestation of sodium disorders, but it is something which can be very, very significant in terms of pathophysiology. We need to understand this in that regards. Now, when we talk about sodium, why is sodium very important? So we need to understand about 2 terms, the osmolality and tonicity. So when we talk about osmolality, we are talking about 3 major osmoles: sodium, glucose, and urea. Now remember, urea can cross the plasma membrane very freely. So effectively, we have got 2 osmoles which are there, sodium and glucose, which decide the tone with regards to the overall aspects of the process. So these are the ones which regulate the tone. And this tone is a very, very important part which is there for the overall body, because if the tone becomes more, the cells will have a different change in that regard. So sodium is the major determinant if we talk about the tone. And if you have hypernatremia, there will be extraction of fluid from the cells, which will become shrink. And that's why hypernatremia can cause a lot of problems in that perspective. Now, tone is one of the most carefully regulated physiological parameter. Even 1% change in plasma osmolality will result in the production of AVP, which will then have a regulation in terms of sodium levels. So conditions which are associated with AVP deficiency or resistance, central or nephrogenic diabetes insipidus, you will have increased tone. The fluid will go out of the cells and cells will basically shrink in that regards, and that will cause irritability. It may even cause hemorrhage in that perspective. Very importantly, after a time, the body will develop adaptation. So the cells will develop etiogenic osmoles within them. So they will regain their shape. So chronic hypernatremia will result in a scenario where the cells will become preserved. But if you now treat it rapidly, like we talked about hyponatremia, you will have a huge problem. So if you have an acute correction, if you have a rapid change in sodium, suddenly the cells will swell up. So the basic response as far as hypernatremia is concerned is in the initial phase of cell shrinkage, while if rapid correction is done, you have a cerebral edema which develops. On the opposite, if you have hyponatremia, you have cell swelling followed by shrinkage, which is known as central pontine myelinolysis or osmotic disequilibrium syndrome. So whenever you are treating hypernatremia, be very careful. If it's a chronic hypernatremia, beyond 48 hours, you have always a risk of cerebral edema, which you need to be cautious in that perspective. Now, when we talk about sodium homeostasis, we know that there are two aspects which regulate the serum sodium concentration, the sodium amount and the water. Now, remember, the actual sodium concentration is more affected by the amount of free water rather than sodium levels. So abnormalities in serum sodium are largely because of a free water problem. So if you're talking about hypernatremia, it is usually because of deficiency of free water, rarely because of sodium excess. And this is an important concept to understand. Now, the two ways in which the free water is regulated: how much water are we drinking? And this is the basic defense against hypernatremia. So if your urine is passing a lot of free water and you're drinking enough water, you will never develop hypernatremia. Therefore, most children who have diabetes insipidus will present to you with polyuria, polydipsia, but will not present with hypernatremia unless their thirst center is defective in the form of a hypothalamic lesion, neurosarcoidosis, or they do not have access to free water, or they are infants because they are not drinking water primarily. So the primary presentation of diabetes insipidus is polyuria, polydipsia. Hypernatremia in that setting happens in infants, post-surgical, neurosurgical, or neurologically ill patients, or if you have a thirst center which is defective. The other, of course, is urine output, which is the primary defense against hyponatremia. And we talked about if you are not able to pass free water in the urine in SIADH, you will have hyponatremia, which will develop in that perspective in that regard. As soon as the tone increases, even by 1%, your extra blood-brain barrier areas like OVLT and subphonical organs will become activated, and they will produce the stimulus for AVP production from the hypothalamus, and this posterior pituitary and hypothalamus, the AVP will cause effect as far as concentration of urine, and therefore free water goes up and the sodium level will again come down in that perspective. On the other hand, if the volume goes down, so in that scenario, the renin-angiotensin-aldosterone system will get activated and will start causing conservation of sodium. The urinary sodium will go down, the potassium excretion will go up in that perspective. On the other hand, if the volume becomes very high, there is the third system which will come into the picture, which is the natriuretic peptide, which will cause loss of sodium in the urine. So effectively, conditions associated with RAS axis will not have hypernatremia. This is an important finding to remember. So as I said, hypernatremia can happen if your free water is less. That is classically you're losing a lot in the urine, which is classically the situation of diabetes insipidus, or if your sodium content is more. Now, if you have too much sodium to eat, if you have got a renin, angiotensin, aldosterone system excess, you will immediately trigger the atrial natriuretic peptide system, which will take off the sodium from the body. So RAS excess states like primary hyperaldosteronism, hyperreninism, Liddle syndrome, upper and middle excess will not present with hypernatremia. They will, on the other hand, present with hypokalemic alkalosis. This is something which is important to understand. Now, water handling, largely most water that we drink is filtered, freely filtered, and it reaches basically the collecting duct, and it's there that it is mainly regulated in terms of water absorption. And this water absorption happens via the action of vasopressin on the vasopressin receptor, resulting in movement of the aquaporin channel towards the membrane. So AVP essentially is increasing the capacity of collecting duct to get out the urine, and this is a 10-time concentration. So in the absence of AVP, your urinary osmolality will typically be around 100 milliosmoles per kg, and if you have maximum AVP, it may go up to 1000 milliosmoles per kg. So in a way, AVP can actually change the amount of free water excretion, reduce it by 10%, by 90%. So this is a huge variation which happens. Now, if in a normal scenario, if your water excretion is low, or if you are low in water, your urinary osmolality will also be, the water excretion in the urine will also be affected. So in normal scenario, if you have a free water deficit, you have a concentrated blood, you should also have a concentrated urine. But if you have a concentrated blood, and when I say concentrated blood, a sodium more than 145 millimoles per liter, a plasma osmolality more than 300 milliosmoles per kg, your urinary osmolality should be less than 600. If that is the scenario, that is diabetes insipidus, but it should ideally be more than 600 if it's a normal response in that regards. So concentrated blood, dilute urine equals diabetes insipidus in that scenario. Now, as I said, that the most sensitive parameter that the body reacts is actually plasma osmolality. Even 1% change, an increase in plasma osmolality above 280 triggers a release of AVP. If you compare that to glucose, if you talk about a normal value of 80 to 120, your effects usually happen when the levels become less than 60. That is like 25% change. If you talk about temperature, you've got wider variations. So most closely regulated parameter in the body is plasma osmolality, and that's the importance of serum sodium levels. So as soon as your plasma osmolality goes above 280, sodium typically are above 138, your AVP will start coming into the picture. And by the time you reach a plasma osmolality of around 295 or maximum 300, you will basically have the maximum AVP secretion. So if an individual has a serum sodium above 145 in the hypernatremic range, plasma osmolality above 300, you will invariably have a concentrated urine. If there is no concentration, there is a problem in either AVP secretion or AVP action in that regards. The threshold for thirst is around 10 milliosmoles per kg on the right hand side. So when you are having a concentration of blood, you will first of all stop the leak. Your urine will come low and the thirst mechanism will become active later on. Because otherwise, if the thirst became active first, you would be drinking and passing in the urine. So when you have hypernatremia, the first response is stop the urine output, then you start drinking more water. Otherwise, it will be a wasteful expenditure in that regards. Having discussed all that, if we talk about hypernatremia, it can largely be because of free water loss. This will result in dehydration. So individuals will be dehydrated, or rarely because of sodium gain, where you will have features of fluid overload. Most common cause is a free water deficit, rarely because of reduced intake, especially in a surgical setting. If you're not giving enough fluids, if the infant is not drinking enough, there will be a free water. In that regards, rarely if there is a gastrointestinal loss, you will have hypernatremia, because gastrointestinal fluid is basically hypoosmolar. So if you're losing that, you will develop hypernatremia in that regards. So diarrhea and sweating, these all will also cause hypernatremia. The most common chronic cause of hypernatremia, though, is diabetes insipidus. in which there is no vasopressin, you will not be able to concentrate the urine. It could be because of a AVP deficiency or resistance. High renin, angiotensin, aldosterone system situations will not really cause hypernatremia. You will have a sodium 142, 143, not in the hypernatremic range, but more of hypertension, hypokalemia, and alkalosis, because the atrial natriuretic peptide system will come in that regard. Similarly, if you have too much sodium load and your kidneys are working fine, you will lose all in the urine and you should not have a problem in that regards. You can also have a scenario of osmotic diuresis like mannitol, hyperglycemia, recovery from renal failure, where these osmoles will drag water with them and you will have a free water deficit. So largely, come up, you can all go and have a look at our website, applications and books. I'll really thank Dr. Naveen and Dr. Sayan for being part of this program, and they've really made it very, very interesting.